Yes, Doc.
Yeah, so I want us to discuss rheumatology today, and basically we'll be looking at two important topics under rheumatology. Basically, these are very common topics that you come across during your clinical practice, and in terms of examinations, and also there are common cases that in terms of rheumatology, you would be seeing what we'll be discussing. There are other rheumatology conditions, but basically we will be looking at these two main ones. You can further on apply the principles to other ones that you see. And as I always say, you can always refer in terms of management if you're not sure. But in terms of the common ones that you'll be seeing, we'll be talking about SLE today. And also in our next discussion, we'll talk about RA. So SLE is systemic lupus erythematosus. Once we are done, we'll try and talk about rheumatoid arthritis as well. So we'll look at what it is, how it comes about, and the clinical features, how we are able to make diagnosis, and then how we manage. Okay, it's basically straightforward. Main principle is getting what it is and how it arises. And once you get this, you can always direct your investigations to it, and then you can manage accordingly. So when we talk about SLE or systemic lupus erythematosus, for the sake of this lecture, we'll be using SLE because it's quite a mouthful sometimes. So when you look at it, it's actually not a disease condition that affects just one organ, okay? Or it doesn't affect one organ system. It's actually a multi-systemic condition, okay? When we say multi-systemic, it means that once you develop SLE or systemic lupus erythematosus, once you develop something of this sort, then we are looking at not just one organ, but you having challenges with multiple organs where as we go on, you realize that it can affect, apart from the main things that they would tend to present with, that is skin manifestations and joint manifestations, some constitutional symptoms. It can also affect major organs like the kidneys, can affect major organs like the lungs, can affect the neurological system. So it's basically a multi-systemic condition. Okay. And in terms of epidemiology, it is more common in the African American than the other population. And in terms of sex distribution, it is more common in females than in males. So primarily you would say it's a female condition, even though males can get it. It is not so common. More than 90% of SLE would occur in females, and you can see the peak ages usually between 20 to 40 years. Okay, but it doesn't mean that people younger than 20 can be diagnosed of SLE. They can. It doesn't mean that people over than 40 can't be. They can as well. So this condition would usually run a course, meaning that you are going to have moments where the disease condition is basically in remission, meaning you are not having any symptoms at all, and not showing any clinical features at all. And then you are going to have moments where you are going to be showing symptoms, severe symptoms, and we say that you have exacerbations during this period. We say it's a chronic condition, so SLE is not an acute condition. It's a chronic condition, but then in between you can have acute episodes, okay, acute exacerbations. but mainly it's a chronic condition. And once you have SLE or you are diagnosed with SLE, you are going to live with the disease condition for life. So basically, you just have to make sure you are adherent when it comes to the management that you'll be put on. So what causes it? The actual cause is unknown. Okay, just like many autoimmune conditions, we don't know the actual cause. What we know is that it's an autoimmune condition. And an autoimmune condition means that the body basically starts attacking itself. Okay, in terms of definition for autoimmune, it means that your body makes some sort of soldiers, what we call antibodies. And these antibodies would have the name autoantibodies, meaning that these soldiers, instead of they fighting the terrorists that would intend to invade your body, they will rather fight the citizens in the body. So they become autoantibodies. Okay, so the effect of these autoantibodies would, in combination with the antigens they are fighting against, will develop a complex. And this autoantibody antigen complex, once it lands on any tissue or gets to any other tissue, it leads to destruction of the tissue. Basically, that's the principle behind it. The actual cause is unknown, but there are features, or should we say there are certain things that would predispose you to developing SLE. One is if you have a family history. So people who have SLE, once you trace their family history, you realize that there's actually a strong family history of SLE there. Okay, so most people who have it tend to have a family history. So if someone has it now, then you need to advise the person, and that is likely that her daughter might also develop something like that. Okay. Also genetics, where we are looking at the human leukocyte antigen A1, B8, and DRC. Okay, these are like immunology stuff, but if you go deep and you have these things, it tends to predispose you to developing SLE. It's also common in premenopausal women, as you saw the age range. Okay, so 20 to 40, and there's sort of a relation to the hormonal state. So in premenopausal women, we know that their estrogen and all that is working well. So, I mean, it's at a higher level. And so there's some sort of link to their hormonal status and developing SLE. Some medications like hydralazine, isoniazid, procanamide, and penicillamine have all been linked to triggering SLE. So these medications won't cause an SLE, but then if you have a genetic predisposing factor or hereditary predisposing factor and you are exposed to this medications, your risk of developing a flare of SLE is quite high. The same for ultraviolet light. It won't cause an SLE per se, but if you have this familial predisposing factors we've talked about, then the risk of you developing the condition or flare is high. And then of course, exposure to an Epstein virus would also put you at risk. In terms of pathogenesis, we've talked about it briefly, but I would also go over again. So basically, what is happening is that you have an antibody antigen complex, and this antibody is an antibody that has been produced by the body. So what this antibody is doing is that instead of your usual antibodies fighting antigens from foreign invaders, this antibody is actually going to fight an antigen that is natural to the body. Okay, this antigen is not from a foreign invader. And so once you have this happening, then it means that this antibody is going to direct its anger onto the antigen, but forgetting that the antigen is actually part of the body itself, and then it will lead to destruction of vital organs. So basically, ideally, one cell undergoes the natural death and all that's what we call apoptosis. You have remnants of cytoplasmic antigens and nuclear antigens. Okay, you know the cell is made up of the nucleus and the cytoplasm. And when cell naturally dies, you have remnants, just like when the human being dies, you bury the person, they are like remnants there. When a cell dies, you're going to have remnants. So this remnant of the cytoplasm and then the nucleus from dead cells have antigens. And naturally, when a cell undergoes apoptosis, this remnants of antigens are hidden from the body system, because basically we see it as a cell is dead. So we don't want to expose the body system to dead things. So usually the remnants, the cytoplasmic and the nuclear remnants are hidden from the body system. But in SLE, you can't actually hide them. So this remnant of antigen and cytoplasm, antigens of cytoplasm and the nucleus will become exposed. And once they become exposed, your body would see them as foreign substances because they are from dead cells. They are not supposed to be there. Okay, but then the body forgets that these dead cells were once part of your own cells. So your body will direct antibodies towards these antigens from your dead, your dead cells. And once it directs the antibody towards these antigens basically will be known as autoantibodies because they are being directed to antigens of the body itself. Okay. So once you have this autoantibody and antigen coming together, they will form a complex, as you can see. And once this complex deposits on any tissue subsequently, it leads to destruction of the tissue. So basically, that's the pathophysiology. Okay. So of course, if this autoantibody and antigen complex lands on the lungs, then it's going to destroy the lungs. It's going to cause inflammation with eventual destruction of the lungs. If it lands on the kidney, it's going to cause inflammation and eventual destruction of the kidneys. Okay. If it lands on the joint somewhere, then it's going to cause destruction of the joints. Okay. So basically, that's the principle behind it. So the clinical features, you would usually have the constitutional symptoms. Constitutional symptoms are symptoms that are not only related to SLE. So you are going to have something like a fever. They are like non-specific symptoms. So fever, joint pain, weight loss, and all that. Then you'll have musculoskeletal symptoms as well. Okay. So the arthralgia, the myalgia, arthritis, they'll have joint disease. And about 90% of people, they have joint disease. Then they're going to have skin conditions. So they will have a specific type of rash called a malar rash or butterfly rash. Not all of them, but most of them will have a butterfly rash, which we'll be seeing pictures shortly. They can also have a discoid rash, okay, which we'll see pictures. And then their skin becomes very, very sensitive to light. So when they are in the sunlight, the slightest thing, you can get a reaction. So there's actually a triad, okay, means that 3 clinical features. When you have a woman coming to you with fever, multiple joint pains, and a rash, which you are not sure of, you have to entertain SLE and make sure you rule SLE out. So these 3 things, fever, joint pains, and then a rash. Okay, but as we go on, there's an actual criteria for making a diagnosis, which we'll be seeing shortly. And then, of course, they can have effects on the kidney. So SLE patients can develop acute renal failure or chronic renal failure. They can develop pulmonary conditions, so like inflammation of the lungs, which is pneumonitis or pneumonia, can have a pleural effusion, they can have pleurisy, interstitial lung disease, they can have pulmonary hypertension. They can have neuro issues, so they can have seizures, migraines, cranial nerve palsies, they can have psychosis. They can have GIT issues, so ulcers in the mouth. You can see that it's multisystemic, and this is all due to inflammation and destruction of the tissues. And it's all based on the pathophysiology, which we just talked about, the autoantibody antigen complex. Wherever it lands, it just leaves destruction in its wake. Okay. So it can pericarditis and myocarditis as well, as a form of cardiac disease. In terms of hematology, it can cause reduced HB, reduced white blood cells, reduced platelets. Okay. So there's like a picture showing some of the features you can have when you have an SLE, a patient with SLE. So you can see the face, the butterfly rash over there. The rash looks like a butterfly, as you can see. You can see the mouth ulcers, the heart, the inflammation of the inner layer of the heart, which is endocarditis. You can have myocarditis, which is the inflammation of the middle layer, and pericarditis, which is the inflammation of the outer layer, as you can see. The lung conditions too are listed there. You can have kidney conditions, both acute kidney injury and chronic renal failure, muscle pain, joint pain. So you can see classic, all these things are here, anemia, BP goes up and all that. So there's a picture. You can see the malar rash here, or the butterfly rash. See how it looks like. Okay, it's like a butterfly, the wings, and then the bridge of the nose is the middle aspect of the butterfly. Or you can get a discoid rash, which looks like this. It's not classic butterfly. It has a thickened base, unlike the malar rash, which looks a little bit smooth and dotted. The discoid rash looks a bit rough and has a thickened base. Okay. Investigations. In terms of autoimmune, the fact that an autoimmune condition, we are going to look for what we call the autoantibodies. Okay, so the first thing you are thinking about is testing for autoantibodies. And remember, we said that the antigens that the antibodies are directed to are cytoplasmic and are nuclear antigens. So we are going to look for antibodies that usually would fight against nuclear antigens, and that's what we call anti-nuclear antibodies. Okay, so that's, if you see ANA, that is what it means, anti-nuclear antibodies. And then anti-double-stranded DNA, which is written as anti-dsDNA. There are also other autoantibodies you can look out for, anti-Sjogren's syndrome-related antigen, anti-Smith antibodies. These two are sometimes present in patients with SLE, not always, okay, but your autoantibodies most of the time would help you make a diagnosis of an SLE, and your anti-double-stranded DNA. So whenever you are thinking SLE, your initial investigations, you have to do ANA and anti-double-stranded DNA. Okay, you can also do your inflammatory markers like your ESR and then your C-reactive protein, which you can see there. And then, of course, you saw the systemic effect that it can have. So you have to look out for other systems, like a full blood count will give you a picture of the hematology we talked about. So if there's anemia, leukopenia, thrombocytopenia, your full blood count will tell you. Be inquiring if there's a kidney damage. It's very essential. So as you can see, it will tell you. You can do a liver function test if there's any damage there, it will tell you. And then usually the disease will present with reduced complement levels. So most of the time they are also immunodeficient. So they tend to get infections easily. So you can actually look out for the complement level. And then the urine array will come in handy. In terms of imaging, because they're talking about joint pain and whatnot, a joint X-ray of the affected joints is very essential. It shows you what you are looking for in terms of joint damage. Chest X-ray also helps, especially if you have any lung conditions. Chest CT scan clearly if you have any of the lung conditions. Echo, the endocarditis, myocarditis we talked about, the echo, your echo would show you. Pericarditis, your echo would show you. MRI of the brain, it would help you rule out other things, okay? Because remember we said the patient can have seizures, so you want to know what is happening. Sometimes you need to do a lumbar puncture to rule out a meningitis, because remember we said the patients will have constitutional symptoms. If you have a patient who has fever and has seizures, now you're thinking, wow, this could be a meningitis. Maybe this could be a cerebral abscess. Let me do a CT scan or something. if it's a meningitis, so let me do a lumbar puncture in addition and see. But you check and then basically it's not an infection. The labs will come and then you realize that you're actually dealing with an SLE. Okay. And then of course, a renal biopsy would help you if you have a kidney problem and you want to see if it's related or caused by an SLE, what we call lupus nephritis. You do a biopsy. Once you take your biopsy, you can send it for histopathology, and then they will tell you if the inflammation is secondary to SLE. So ACR, American College of Rheumatology, actually have a diagnostic criteria which you can see. So basically, you can go with the mnemonic SOAP brain MD. Okay, so this mnemonic can guide you. And so you can see that inflammation of the serosa, or called serositis. You can see that, and then there's oral ulcers, so as you can see, then arthritis, then photosensitivity. So that becomes your SOAP. Then blood disorders, renal involvement, ANA, which is antinuclear antibodies. There are other immunologic phenomena like anti-double-stranded DNA, neurologic disorder. So that becomes brain, and then malar rash and discoid rash. So we usually say SOAP brain MD. Okay, so it's like a doctor who is called, whose first name is SOAP, and then the surname is brain. So SOAP brain MD would give you serositis, oral ulcers, arthritis, photosensitivity, blood disorders, renal involvement, ANA, your other immunologic involvements, your neuro involvements, malar rash, and discoid rash. Okay, once you remember SOAP brain MD, at least it should guide. So if you have any of the above 4 of the things that we've talked about, and this 4 should at least have 1 clinical feature and 1 immunological feature. So the immunological feature here is the ANA, or the anti-double-stranded DNA that we talked about. So you should at least have 1, or you should have 1 of the clinical features to make it 4. Once you have this, then we can say that, okay, you have a systemic lupus erythematosus. Or if you are suspecting a patient has kidney problems and you take a biopsy, and then the biopsy comes back and is positive for lupus nephritis, and you have ANA also being positive or anti-double-stranded DNA also being positive, then clearly we can say that you have SLE. In terms of management, it's pretty much straightforward. So it's a chronic disease. You need to counsel your patients. You need to advise your patients. They need to be adherent, because most of the time, that is one of the issues we face. Most patients are not adherent to their treatment or their therapy, and it brings or it causes a whole lot of problems. They need to be adherent to their therapy. You need to avoid exposure to sunlight, as we talked about. We said that sunlight tends to be a trigger factor. You need to avoid smoking, which is also a trigger factor. And then when we look at pharmacotherapy, there are usually 4 main classes of medications. If you get a question on SLE, I would ask you this pharmacotherapy, because you should know. If in your licential you get a question on SLE too, you'll be asked. So the first group of medication is NSAIDs. So at our level, we can usually prescribe NSAIDs for the patient. And if we make the diagnosis of SLE, we can add maybe chloroquine to it and then refer to a rheumatologist, or you can just refer after you've given your NSAIDs. So example, diclofenac, naproxen, and all that. The other class of medication is the anti-malarial. So we put them on chloroquine or hydroxychloroquine, okay? And then you also have to put them on steroids, because everything we've been talking about is inflammation, and steroids have anti-inflammatory properties. So you put them on methylprednisolone or prednisolone, okay? Then you have what we call the DMARDs, or disease-modifying anti-rheumatic drugs. And every patient who has a rheumatological disorder should at least be on this medication, because it modifies the disease as it modifies the course of the disease, and it comes with better outcomes when you add it to your treatment. So they have the non-biologic type, which includes cyclophosphamide, methotrexate, azathioprine. Of course, these are medications that would also suppress your immune system. So we always need to be careful, and that's why you need to counsel your patient that the disease itself can actually suppress their immunity in a way, even though their system is reacting against each other. The fact that complements will reduce means they are prone to infections, and some of the medications you give would also put them at risk of infection. So you need to counsel them. And then when they are running temperatures, you need to admit, because you are not so sure if this is a flare they are getting from the disease or if they have a very bad sepsis because of that immune suppression. Okay, so the biologic agents, rituximab, all those monoclonal antibodies, the medications that end with MAB, meaning monoclonal antibodies, you can go ahead and then give such medications. Then IV immune globulin, you give to the patient, and then it helps the patient a lot. So SLE is straightforward. I just need you to know the pathophysiology, which will antibody and antigen reaction, which would come together and then would basically destroy every multisystemic. You should know the systems, and you should know the disease conditions that that it comes with, because I mean, we can ask you, or you can see a patient who has SLE, but the presentation will be joint pains and cough. Okay, so you need to be apt, you need to think deep. The patient has joint pains and is coughing. Maybe this is just an upper respiratory tract infection, but then you need to ask the patient, how long have you been coughing? If the patient tells you, I've been coughing for a very long time and it's on and off and it's been years, then you know this is not just any upper respiratory tract infection. This is a chronic condition. So you are thinking, could this chronic cough be tuberculosis? Okay, or because tuberculosis, you can also have a multisystemic condition. So you are planning your investigations along that line. Or the patient is a female, she's in a reproductive age. Okay, how long has the joint pain been? Do you have anybody in the family who tends to develop something like a joint pain or has a rash? Then you're looking out for the rash yourself. So, I mean, trying to diagnose SLE, you need to put in effort. Otherwise, you misdiagnose, and then you keep giving your patient NSAID, and you've been managing as musculoskeletal pain. Most of the patients we see in our private facilities or wherever we see OPD and we say, oh, musculoskeletal pain, then you just put on terminal, especially the females, some of them have SLE or rheumatoid arthritis, and they've been missed until they come with deformities before. Because if you miss a patient with SLE, the patients will come to you with a lupus nephritis, and this patient might end up developing a chronic kidney disease and end-stage renal disease. Okay, so we need to be cautious and careful when we have that combination of joint pains, rash, and some form of constitutional symptoms like a fever. We need to look out for the other systemic conditions. Okay, so I think this is it for SLE. I'll take questions and then we will quickly touch on rheumatoid arthritis. So if you have any questions, you can let me know. Are we okay?
Hello, sir.
Yes.
Hello, sir. If you do you have any concerns? Maybe if you want to give a corticosteroid with some of the disease-modifying drugs like the methotrexate, combining it with the corticosteroid, won't it cause any much of immune suppression to the patient?
Okay. Yeah, so that's a good question. So there's a risk of immune suppression, as I said, but then it doesn't mean we don't do that combination. Sometimes you can have a patient being on all the 4 classes of treatment. You can have a patient being on some NSAID, hydroxychloroquine, some prednisolone, and methotrexate or azathioprine. You can have it happening. It's all dependent on your follow-up for the patient. And that is why I said that adherence and follow-up is key. Because if you develop this rheumatology condition, it's an expensive disease, not just about money, but also your whole life changes once we make a diagnosis of a rheumatology condition like an SLE or rheumatoid arthritis, which we'll be talking about. Your whole life changes. So you need frequent follow-ups, okay, so that we can know that you are improving. We won't put you on high dose medications that will put you at risk of infections. You only go on high doses when you have moments where you are flaring, okay? You have flares. Flaring means that the disease has basically moved out of remission and it's become severe, okay? But once we are in remission and we are giving you some low maintenance doses, you should be okay. But if you are not adhering to your medication or you are exposed to something, or we tell you avoid sunlight and then you go and expose yourself to the sunlight, some trigger factors, then you have a flare, then now we would have issues in terms of medication dosages because we might need to increase your dose a bit just to get you back into remission. And that also comes with the risk of the infections, right, in terms of reduced immunity. But once you are given your maintenance doses and all that, you don't really have to worry so much. You just need to follow up and then monitor your patients properly. Are we okay?
Thank you, Doc. Yes, Doc.
Yes,
But
you're
Doc,
welcome.
please, at our level as PAs, are we allowed to give methotrexate, and what is the dosage, the recommended one?
Okay. So no, so you are not allowed to. Okay.
So no,
So
so you are not allowed to. Okay.
I won't
So
I won't recommend that
I won't.
you make a diagnosis of SLE and puts the patient on a disease-modifying anti-rheumatic drug. You leave that to the rheumatologist. So let me add, even the rheumatologist won't manage SLE alone or rheumatoid arthritis, which we'll be discussing shortly. It's a multi-systemic condition, so you need to go according to what we term as a multidisciplinary approach. Okay,
according to and what we term as a more.
so you don't manage it alone on your own. If you are giving a DMAT, then it means that you are going to follow up the patients yourself and all that, and that is not your area of expertise. That's why I said that even though it's there for you to know, but then in terms of management, you can go ahead and give your NSAIDs and sometimes your steroids, sometimes the hydroxychloroquine or chloroquine, but even that would say once you've made that diagnosis and you've started your NSAID, just write a referral and let them go and see a rheumatologist. It's good that you know what the rheumatologist will do, but it doesn't mean that you will do it. It's just like being able to diagnose appendix. You are not a general surgeon now, so it is not your problem to go and perform an appendectomy for the patient, but you need to make that diagnosis so that the skilled person will take over and perform the necessary procedure. But you need to know the procedure that is going to be performed for the patient. Okay. Are you okay, please?
Yes, Doc.
Okay. So let's move to rheumatoid arthritis. Yes, please.
Hello, sir. Yeah, with the systemic lupus erythematosus, the body, the immune system, the immune surveillance. Why can't the immune surveillance not pick this thing? Because we have these pattern recognition receptors, which is broad, which can recognize this double scan, maybe linking this in the cytoplasm. So why can't the immune system pick up this
Yeah.
double-stranded RNA or DNA of the virus.
You mean why can't the immune system identify the antigen as self-antigens rather than seeing them as foreign antigen? It's not a virus. The antibodies are not being directed to a virus. The antibodies are directed to your antigens yourself, the antigens that form part of your cells that are dead. Okay, so it's not that the antibodies are directed to a foreign invader. No, they are directed to antigens, and these antigens are not foreign antigens, but antigens that were produced by your body, your cells some time ago, but are currently dead. Okay, and you're right. That's why in the initial aspect of the lecture one, I said that in terms of etiology, the actual cause of SLE is not known. But what we know is that there are risk factors that will put you, or there are factors that will put you at risk. And I said something about family history. So some of these things go way back into genetics, okay? And it's the genes. And then if you joined the lecture earlier, you would see that I talked about some human leukocyte antigen, HLA-A1, B3, D3, DR3. These are like, you are going into the molecular level, okay? So some things are not supposed to be there in the system, but some people are born with your system is unable to identify the normal body cells, and your system starts seeing them as foreign invaders. You understand? So they are, even though your normal system ideally is supposed to be able to recognize all these things, when your system in quotes is not normal, you'll be unable to recognize these things. And what makes the system not normal is what we talked about in terms of the etiology, the fact that maybe you might have inherited something from your generations, before, or the genes and all that. That is what would make it impossible for you to recognize this antigen as a self-antigen, and you rather attack it, okay? And that will lead to destruction of the cells. I don't know if you are okay with that.
Yeah, that's clear, but there's also an environmental factor to it. There's also environmental where people believe viruses could mimic those.
Okay, so the environmental factors there, okay, something like ultraviolet light, or you are talking about the Epstein-Barr virus, for instance, those are environmental factors, but those ones are not, it's not the cause of the SLE. If you read deep into SLE, it will tell you that most people who would start showing symptoms, if you had tested them in the past, you realize that they have some form of SLE. These environmental factors are only trigger factors. They are not the cause of the SLE. You understand? So ultraviolet light is not the cause of SLE. If it was the cause of SLE, then like all of us working in the sunlight will develop SLE. Epstein-Barr virus doesn't cause SLE, but it is a trigger for those who have these issues with the genes. The main factor is not known, but then some genes have been identified that if you have these genes, then you are at risk of developing SLE when you are exposed to trigger factors. So those environmental factors are not the actual cause, they are just trigger factors. Are you okay? You get it?
Yeah, I'm okay. But so with the human leukocyte antigen, with a broad assortment, it can reshuffle to generate a whole range of antibodies. So when there's this mutation over there, when there's also a mutation, because of its broad assortment function, it can also be, so when the virus, as you said, we don't know the known factor, we don't know the known cause of it, but some believe that, okay, when there's a mutation of the HLA, when there's a mutation and there's a viral, like there's a viral component of it, it can trigger those responses to mimic. So the virus is just mimicking what ourself, it's just mimic ourself from the non-self.
Don't confuse yourself. Oh. you end up confusing yourself. What you should know about it is that not everybody, if you are looking at that case, then you would have to say that everybody who has SLE and starts showing symptoms of this SLE should have been exposed to a virus that is basically triggering the SLE, but not everybody with SLE and its features would be exposed to a virus like an Epstein-Barr virus or a virus that triggers a change in your system. Do you get what I'm trying to say? So the virus bit is just one aspect. You see, the virus bit is just one aspect, and that virus bit is not what is going to cause you to have the SLE. This is not like an HIV, this is not like HIV/AIDS, okay? Not like HIV/AIDS where we know that you develop AIDS or HIV/AIDS, which is a multi-systemic condition when you are exposed to the HIV virus. That is like straightforward, okay? This one, you can still develop your SLE without your exposure to viruses. Your SLE, you can develop the SLE after, or you can show clinical features of the SLE after you have been exposed to other trigger factors like even medications, which we mentioned. So the virus is not like a major component which is actually going to lead to the SLE. It's just a trigger factor.
Okay.
Did you get it?
I'm not disputing. Yeah, you are right. I'm not disputing it. I'm not disputing, but I'm also coming with the fact. I'm not saying that it's only the environmental is the major.
Okay, let's go on. Let's go on. We will become confused. Yeah, let's go on. All this plenty talk.
No,
because we are getting it.
Look, I'm confused.
He's confusing us the more.
Let's go on.
So what you can do is, you guys, I've told you several times to create a page, and you should be putting things like this there for us to discuss. So this should provide the opportunity for you to create the page.
We have that page.
Okay, so you can put this thing there where you have issues in terms of trying to understand. You put it there, and then we'll discuss, and then we'll back it with studies, and it will make things clear to you. You understand?
Yes. So let's go on.
It's not a matter of data are running. They don't have data. It's staying like that.
Hello, Doc.
So, yes, please. Yes, hi. I can hear you.
Please, do you think you should also do maybe STD, the way SLE presents looks like you may also mistake it for
sickle cell disease,
an STD. So do you think we should do a screening for STD as well?
You mean STD, a sexually transmitted disease? Or sickle cell disease?
Sexually transmitted.
All right, okay. So maybe like a gonococcal arthritis. Well, yeah, I mean, you can screen for that. You can end up screening for that. But you see, sometimes that's why you take a history before you request for investigation. Okay. So clearly, if your patient comes to you and is giving you a history and it says history linked to a sexually transmitted disease, you would know. And then you can request your investigations as such. But if they are giving the history and the patient is telling you that this thing is chronic, it's been there for years and all that, then it's actually pushing you to a certain part, okay? So unless, of course, you are thinking, all right, maybe this is a sexually transmitted infection, the person is giving you a history, which is because syphilis can happen for years, and it's directing you to syphilis. And of course, as I said, the history is key. The person won't just come and start telling you about joint pains and whatnot. They'll tell you about the first time they saw this, maybe there was an ulcer in the genitals, and then later it went away, and then later there was this, that. So that builds up the history for you. So if they are giving you a history, which as medical professionals now, we say that there's something that gives you any history that in any way makes you think this can be of a sexual origin or probably an STD, you need to try and then screen for what you are thinking it is. Okay, but it is actually not so classic. Me, I was even thinking you were talking about sickle cell disease because of the pain and maybe some of the other features. Okay, but of course, you need to screen your patients for diseases during your history and your examination process if you think that what they are presenting with might probably be what you are thinking it is. If you screen and it's not it, then it means you've ruled that out. Okay.
Thank you.
All right. Okay. So the next topic we'll talk about is rheumatoid arthritis. It's also quite straightforward, a bit similar to the SLE we've talked about because it's also under rheumatology. Okay. So this is also a systemic disease, basically. It's a systemic disease. It's a chronic disease. So similar to SLE. We said SLE is a chronic disease and it's a multi-systemic disease. Okay. In rheumatoid arthritis, we have what we classic features, or what we call polyarthritis, meaning that you have arthritis in many joints, okay, more than 2 joints, we say polyarthritis. And then once you have this arthritis tends to be symmetrical, okay? So it means if you have inflammation of your right, wrist, you are going to have the same thing on your left. If you have inflammation of your right forefinger, you are going to have the same thing on the left forefinger. It's basically symmetrical. So once a patient comes and you are taking the history and they are telling you, oh, they have symmetrical polyarthritis, then they should direct you to start thinking of a possible rheumatoid arthritis. Okay. And one of the things that you help you differentiate from other things is that the other form of arthritis might be asymmetrical or will be monoarticular. Let's say you have your patient comes and says, I have pain in my right knee. It would usually not click as a rheumatoid arthritis because it's just a right knee. So this is likely to be what? Osteoarthritis. Okay. So the fact that it's polyarthritis, the fact that it's symmetrical, and the fact that it is chronic should help you make that diagnosis. And of course, the fact that it's multisystemic should also help you. Okay, so we're saying that it would usually affect the hands and the feet, but then any joints where you have synovial membrane can also be affected. The peak age is about 30 to 50 years. Okay, and just like SLE, the premenopausal women are affected more. In this case, when you are looking at the premenopausal age, more women are affected than men, as you can see. But then once you go beyond that age of menopause in women, the male to female ratio is basically 1:1. Okay, and also this one has strong association with the HLA or human leukocyte antigen phenotypes. Also, you can have trigger factors like infectious agents, mycoplasma, Epstein-Barr virus, rubella virus, which would basically act as an external trigger. Okay, and usually once they act as a trigger, you are going to have that kind of autoimmune reaction in this case. And then you are going to have effect of the synovial membrane, which is lining the joint. So we are going to have synovial hypertrophy with chronic joint inflammation and then destruction of the joint. And also you are going to have extra joint manifestations as well. Okay. So it's basically the genetics play a very key role, as you can see, because if that genetic base is not there and you're exposed to any of these trigger factors, nothing will happen. So, because we are all exposed to infections, trauma, smoke, and all that, but then it doesn't cause us to develop severe reactions in our joint and destructions of the synovial membrane. Okay, but as you can see, with people who are genetically susceptible, they can end up developing something of that sort. Okay, so when you go down into immunology, you see that there's actually an immune base or immune foundation there, okay, where basically you have T cells, macrophages, all involved in a certain cycle, and then there are also production of what we call autoantibodies, similar to what we talked about previously. In this case, you have the rheumatoid factor as one of the autoantibodies being produced. Okay, you can also have what we call the anti-citrullinated cyclic peptide, which cuts short anti-CCP antibodies that are produced in rheumatoid arthritis. So remember in SLE, we were talking about anti-nuclear antibodies, which is ANA, and then anti-double-stranded DNA. In this case, we are talking about rheumatoid factor and anti-CCP. So if you are not sure of the condition, then you can request, and then once it comes, in some cases, your anti-CCP comes, is positive, and then clearly points you to the fact that you are dealing with rheumatoid arthritis. And it's not just that with your anti-CCP and your rheumatoid factor in combination with the features that you have, that should guide you in making your diagnosis. So presentation types, there's the palindromic type, and this one is not like the classic rheumatoid arthritis, because as you can see, we said rheumatoid arthritis is polyarticular and it's chronic, but then the palindromic is something that will just happen one joint, lasts for about a day or two and it goes away. Okay, so it's not a classic. But then coming down, you have the transient, which would start, but within 12 months, it would disappear and it will leave no damage at all. Then you have remitting, which several years, you're going to have active arthritis, which will go away by itself, and then will leave very, very minimal damage. Okay. Then there's chronic persistent. So this one, there's a relapse where you have severe disease, then it goes into remission. Then another relapse, then it goes into remission, and it happens for a very long time. Then we have the rapidly progressive type where the disease starts and in a few years, there's severe damage to your joints. Okay. So as you can see, typically your rheumatoid arthritis will be slow and progressive. We've seen the fact that it will be symmetrical, and then it would involve multiple joints. Then usually you have pain in the joint, and then you have stiffness in the joints. Most of the time, the joints, small joints in the hands and the feet, and it's worse in the morning. When you wake up, you realize you have severe pain in your feet and your hands, and your feet and your hands, the joints become very, very, very stiff. Okay. And also, apart from your small joints in your feet and your hands, it can also affect the wrists, the elbows, the shoulders, knees, and ankles. But that's not the classic. Classic is small joints becoming very stiff and then very painful, and worse in the mornings. And then sometimes it's warm when you touch because of the whole inflammatory process. Okay. And with time, you are going to have severe damage to the joint, and then you're going to have issues with movement, so movement limitations and muscle wasting. Then the deformities will also start. So if you have the joint inflammation for a very long time, you can develop hand deformities. So you can develop what we call the boutonniere deformity of the thumb. Okay, it's like when you are trying to close a button, the way your fingers will go. So this patient is going to actually have issues and will be even unable to button the thumb. Okay, so that's called a boutonniere deformity of the thumb. Then, yeah, you can also have the swan neck deformity of the finger. So the finger looks like the neck of a swan, like a Z. Okay, as you can see, it looks like something like a Z. Then they can also have ulnar deviation of the metacarpophalangeal joint. So, when you are standing in the anatomical position, the aspect and the part where your small finger is the ulnar aspect. So your hand can actually deviate towards. So when they come to you in the consulting room and you see their hands, you realize that it's actually deviated. And that's one of the ways that can help you make the diagnosis. You can see the swan neck appearance and then the ulnar deviation. It would help you make that diagnosis. Your non-joint or your extra articular manifestations, you can see from here all the way. So you can have issues with the eye, so the scleritis. They can have dry eyes, or we call Sika syndrome or Sjogren syndrome. They have lymph nodes. Because of the issues with the bone, they can compress their spinal cord and they can have paralysis. The lungs, you can see pleural effusion and fibrous nabulitis. They have what we call Kaplan syndrome of the lung. You should just read about it. It's basically having this pneumonia there. You have people who have lung conditions in rheumatoid arthritis. Okay, you can also develop what we call splenomegaly, and once you are looking at it, we call something Feltis syndrome. Okay, so we take a look at that one as well. Then they can have carpal tunnel syndrome as well. Then you look at their tendons and all that, they have issues with that as well. So multisystemic, you have a lot of features here. And once you have the patient sitting in front of you, you should be able to make the diagnosis. Okay. Any questions so far? So just try, when you take the picture, look at it and then look more at your syndromes where you can have a splenomegaly, and then you can have some form of anemia or neutropenia there, what we call the Feltis syndrome. You can look at the other clinical features of the lung. You can look at what your Kaplan syndrome is, okay, where you have a patient where the lung tissues have basically become very, very scarred, what we call the pneumoconiosis in rheumatoid arthritis. So you can just take a look at all of that. You can also have heart issues, inflammation of the heart. So you can see the pericarditis there, which is inflammation of the external aspect of the heart. Complications, the tendon can rupture, your joints can rupture, they can have infection in the joints or septic arthritis. And when they're exposed to Staph aureus, cord compression, which can lead to paralysis, can also have amyloidosis. Investigations, as I said, rheumatoid factor, anticyclic citrinated peptide, and these are autoantibodies that you look out for. Then inflammatory markers like ESR, CRP, you can look out for that. Your full blood count, your imaging, that's your X-ray, your CT scan, and all that. If you have fluid in the joint space, you can aspirate the fluid, and then you go for culture and sensitivity or do microscopy. So in terms of diagnosis, here, if for more than 6 weeks you're having morning stiffness or stiffness in the joint and you have arthritis in more than 3 joints, then we are beginning to think, okay, you are developing some form of RA over here. So morning stiffness, arthritis in 3 or more joints or more than 2 joints. And usually when the arthritis is of the hands, or maybe you are looking at arthritis of the feet or something, with that stiffness worse in the morning for 6 weeks, then possibly we are looking at an RA. Okay. They are saying this arthritis should be symmetrical, which you can see there. There should be rheumatoid factor is not always present, but most of the time it is there. Your subcutaneous nodule, where you see some nodules right under the skin, and then your imaging will also tell you. So if you have about 4 or more of these things, you can go ahead and then make a diagnosis. Similar to what we said about SLE, where if you have 4 of the clinical features with an immunological feature, you can actually go ahead and make a diagnosis. Okay. So once you are looking at management, it's a multidisciplinary condition. Your rheumatologist will come in, your orthopedic surgeons will come in, your neurosurgeons will come in, because this is like a bone thing. It can affect the spine, it can affect the nerves. And of course, it's an immune condition, so you need a rheumatologist. You need to educate your patient, okay? And then physiotherapy is also vital. Then pharmacotherapy is a bit similar to what we discussed. They also put them on the same kind of medications like the NSAIDs, which we talked about before, the steroids, very key because of the anti-inflammatory feature, and the disease-modifying anti-rheumatic drugs, where you have the non-biologic types, that's the sulfasalazine, methotrexate, all those ones, cyclophosphamide, all those ones, leflunomide, all the biological types, okay, the monoclonal antibodies, and tumor necrosis factor alpha and all that. So this basically this is RA or rheumatoid arthritis. It's quite straightforward, and we try to learn both of them together so that when you forget because you had read the other one, you know that, okay, you expect to get these features in this one. So you can always compare and contrast whilst you read. So we've gone past our time. We'll take questions and then we can close for today. So any questions? To understand.
It's not difficult, sir.
Hello, Doc.
Yes, please.
Yeah, Doc. Please, I read it somewhere in treating rheumatoid arthritis. I saw omeprazole and penicillin. I don't know.
Yeah. So the prednisolone is part of the steroids. If you look at the slide, that's it. So yeah, you can give methylprednisolone or prednisolone as part of the treatment. But the side effect of your steroids is what? Gastritis. If you put a patient on steroid for too long, they develop gastritis. So sometimes whilst you are doing that, you have to add something to it, like a proton pump inhibitor or H2 receptor blocker, and that's why the omeprazole was added to the treatment. Okay. Also, if you are putting your patient on the steroid and the patient is on an NSAID at the same time, you know your diclose will also cause gastritis. So it's good to protect the stomach lining. So that's the reason.
Oh, okay. Okay, Doc. Thank you very much.
You're welcome.
Okay, sir, please, I have a question.
Yes, please.
Yeah, you said with the SLE, if you will see those 3.
Yeah, hello. Hello.
Hello, Doc. Hello, Doc.
Yes.
You said with the SLE, you have to look out for the three clinical features together with the immuno marker or something. He said something
The
like that.
immunological feature.
Immunological feature. So, but with the rheumatoid arthritis, you only said the clinical features you have to look for. You didn't add the immunological feature. Doesn't mean that one you don't have to look for the immunological
Okay.
feature as well.
Okay, so with the SLE, as I said, the three features of rash, fever, and a joint pain, it's not a diagnostic criteria. It's just supposed to prompt you or direct you to start investigating for SLE. The diagnostic feature is the subbrain MD we talked about, and we said you should have 4 of those features, and it should include at least one immunological feature. That's for SLE. For your RA, I gave you a list, and not all the patients would have rheumatoid factor, but if the patients have this morning stiffness, polyarthritis, and all that, it doesn't mean that because they don't have the rheumatoid factor, it is not RA. Do you get what I'm saying?
Yes, sir.
So you won't find it in all the patients. If it is there, it makes your diagnosis easier for you. But some patients won't have it, but they would have these clinical features, and then the polyarthritis, symmetrical joint pain. Those ones are very, very essential. Morning stiffness, polyarthritis, which is symmetrical. Okay, once you have that, it's very, very essential. But if you're lucky enough to have a rheumatoid factor present or anti-CCP present, it even makes your diagnosis even stronger.
Okay, thank you very much, Doctor.
You're welcome. Okay, so you need to divide yourselves into 6 groups, so you have to work on it yourself. I'll give you 6 topics. We'll be having that discussion over the weekend. Saturday and Sunday, I'll try so that we can have 2 sessions. We'll have a session on Saturday and we'll have a session on Sunday. So 3 groups will present on Saturday, 3 groups would present on Sunday. This would contribute to your marks at least 30%, so that you know you have just 70% to make up in your exam. I don't know how you are going to do your groups, but I'll be glad if I have a mixture of regular and weekends. Of course, there'll be extra marks to a group that would have that kind of variety in there. It means that you've shown teamwork, okay, which is very essential. So find out, try and get that one done. And just don't let one group be so more than the other or so less than the other. It should sort of be an average, okay, because I'll need the class list from the class reps as well. And then I expect that every group should have the names of its members on the next slide. The first slide should have the topic title, then the next slide should have the names and index numbers of each of the group members, okay? And then try and do extensive research and prepare very nice slides. You can even reference people's study that they've done so that you have rich slides, and then you can come and present to us. You would have, each group would have 15 minutes to present. Maximum, you would have 2 people presenting for each group. If you have just one person who wants to present for the group, that is perfect. Otherwise, maximum, you have 2 people presenting for each group. You have 15 minutes to present, and then we would ask you questions. Maybe we can even give you a case study, and then the group will have 5 minutes to answer the case study. Okay, so you can put the topics down now. So group 1, you present on malaria. Okay. Group 1 will present on malaria. So you can put it down. Group 2, we are going to present on common sexually transmitted infections. Okay. Group 2 will do common sexually transmitted infections. Did we do cholera last semester?
No, sir.
Okay. So group 3 would give us a presentation on cholera. So malaria, sexually transmitted infection, cholera. But we did meningitis.
Yes, please.
Yes, sir. Sir, please, the STI, could you be a little bit specific or like?
Oh, okay. Well, yeah.
just-
So commonly transmitted sexual infections, except HIV. Okay. So HIV is a big topic on its own. So you try and put slides up together. The slides should have something on gonorrhea, something on syphilis, something on HPV. Okay, I know they are broad topics, but then you can go straight to the point. So in terms of what the disease is, mode of transmission, the incubation period, clinical features and management. Then maybe you pick the next one, maybe HPV, what's the diseases, mode of transmission, incubation period, clinical features and management. Okay, so that is for the group that will be doing the STIs. I want to see something on gonorrhea. I want to see something on chlamydia. I want to see something on syphilis. I want to see something on HPV. And lastly, I want to see something on HSV. So 5. Okay, but it's straightforward. The disease, organism involved, mode of transmission, incubation period, clinical features, and treatment. Okay, just give us a very nice presentation. So malaria, sexually transmitted infections, cholera. Group 4 will give us cholera is not so big a topic. So group 3 will give us a presentation on gastroenteritis and try and zoom into cholera. Okay, that's for group 3. Afterwards, I'll also give you my slides on all these topics, but I want us to do team-based learning. So gastroenteritis, and then you zoom into cholera. That is for, yeah. Yes, please.
The slide. Would everyone present on what he or she or one person will present on all of them?
Yes, so I'm saying I would like one person to present on all of them, but maximum 2 people can present for each group.
Okay.
So you need to nominate someone who will be able to present well on your behalf.
Okay, sir.
Okay. All right. Okay. So that is 3. Group 4 will also do a presentation on anemia as a topic. So I want to see the definition of anemia and the types of anemia. So I want to see something on iron deficiency anemia, folate deficiency. So that is for group 4. Okay, so group 4, you would give us something on anemia. Group 5, you would give us something on epilepsy. Okay, so group 5 would present on epilepsy. And then the last group, group 6. So you see, I'm giving you easy topics. Easy and straightforward topics.
Are you sure?
Group 6, would you like to take HIV, or you guys want me to teach HIV in class?
Yeah, please teach.
I should teach HIV.
Yes.
Okay. Okay, I will teach HIV. Okay.
STI for the move.
All right. So
Group 1, your one is too cheap.
Group 6, you give us a presentation on vascular disorders, like bleeding disorders. So you give us a presentation on bleeding disorders. I should see something on hemophilia. I should see something on von Willebrand disease. Okay. So you give us something on platelet disorders, and then
so difficult.
Coagulation disorders. You see, this topic is like the easiest topic ever.
Yes, yes.
People being books.
We know.
It shouldn't be difficult.
Yeah, so it's straightforward. That's why hemophilia A, hemophilia B,
If the lab people are shouting, it's not difficult because
so the lab people can be in group 6 and give us a nice presentation. So these are six. So Saturday, groups 1, 2, 3. Groups 1, 2, 3 will present on Saturday. And then Sunday groups 4, 5, 6 will present. Okay. But within the week, I am going to give you a lecture on HIV. I'll also give you a lecture on stroke. These are like major topics that I think we should do in class. So I'll give you a lecture on HIV. I'll give you a lecture on stroke. I'll give you a lecture on Guillain-Barré and then multiple sclerosis as well. You see, I should have given this to you guys to present. Multiple sclerosis or Guillain-Barré.
So what is the other one? What Barré?
Guillain-Barré syndrome. I'll give you a lecture.
No.
Yes, please.
No, you said the grouping should be a combination of both
regular and weekend. Yes, please.
It will happen.
But the weekend we already have the groups. I think
try and merge with the regular students, and then
Thomas, your people
come up with 6. Come up with 6 groups.
We'll talk to you on the background according to the groups, because the weekend will say that they can only meet on weekends, and the regular would also say
no, but you don't need to meet on weekends or regular. You can always do virtual, and you can have a discussion anytime. You don't even have to meet. You can create a WhatsApp group. You can create a WhatsApp group. You can create a WhatsApp group and discuss. This is it's called teamwork. You should. So try and work it out. People are doing programs. People are doing programs with other international students. One is in India, one is in Australia. You have someone in Ghana, but they all end up having a group work. One is 20, one is 24, one is 34, one has 6 kids, one doesn't have any child at all. It gives diversity. You understand?
So we are not in normal time.
Yes, so that is why we are supposed to make it work. So that one is not negotiable.
Don't worry, we'll figure it out.
Yes, figure it out.
I think
So you have 1 week. You have 1 week to put things together. That's a lot of time. So group 1, 2, 3. I would expect your presentation on Saturday, groups 4, 5, 6 on Sunday. But in the meantime, we'll meet on Wednesday and Friday to discuss HIV, stroke, Guillain-Barré, and then multiple sclerosis. Then after the presentation, we can move on and do emergency medicine and start preparing for exams. Okay. So also think about your time for the exams. The time for internal medicine 2 exam would be this month. So think and give me a date. We'll finish internal medicine 2 next week. So it will be this month. It will be this month. So think and then give me a date. Okay, look at the calendar. Maybe it can be the last Friday or Saturday. Friday. I mean, what you decide. Just give me a date. Your emergency.
Are you writing in school or Zoom?
Yes. No, you are writing in school, please.
Let's do Zoom. So you mean
if you yesterday your senior colleagues wrote, if you write virtual, there'll be a lot of resets. So let's write in class, please.
Hey. Don't worry, we like
No, because listen, if you write virtual, I won't give you number 1 ABC. I won't give you that. I'll give you essay type questions where you have to write in paragraphs and you have a very short time to submit instead of the sitting where you finish in 3 hours. This one I'll give you 8 hours, but trust me, I know a lot of people will still not finish. Okay, and we'll use a system that right after the 8 hours, we won't take any more papers. We'll just stop taking the email. So you think about it. If you want us to do it that way, I'm all up for it. But
it's okay. We want it to class. We want to write.
Oh, so we would like that, but we right. Feeling from it.
It's okay. We like the class. You come.
You come the class. Don't worry.
Okay. So all the best. Let's meet on Tuesday and Wednesday. Sorry.
Right.
And then Wednesday, Friday. Let's try and finish up. All the best.
Thank you, Doc. Have a good evening.
All right, great.
Evans, mute your mic.
Nick.
Evans.
Nick.
Yeah, Evans.
Yeah, are we having it? Are we having additional discussion?
No. We're just terminating the group. So.
Actual schedule to say.
Meaning anything for now, but I'll see what we can do.